Well, hi everyone, and greetings from Northern Michigan. This is Bob the Science Guy, and today we're going to continue with part 3 of my discussion with Dr. Bryan Peck on the controversial video Plandemic. In today's episode, we're going to hear them talk about how coronavirus was not man-made, but did come from the lab. So let's get on with the interview.
Do you believe that this virus was created in a laboratory?
I wouldn't use the word created, but you can't say naturally occurring if it was by way of the laboratory. So it's very clear this virus was manipulated. This family of viruses was manipulated and studied in a laboratory where the animals were taken into the laboratory. And this is what was released, whether deliberate or not. That cannot be naturally occurring.
Bryan, one of the big interests that we have right now is whether or not this was a deliberate release from China. If you're going to weaponize a biological agent, do you test it out on your own population, your own general population first before you release it on your targets? I mean, does that make any sense?
No, not in any way, shape, or form. Why on earth would I kill off a good portion of my own folks as a test run?
Yeah, I'm not going to test nerve gas on my grandparents, you know. Chemtrails, maybe. No. We can't talk about that. But in any event, why on earth are you going to poison your own population with an agent like this? One that, they denied existed to begin with. They had their own issue of denial. It took them about a month to accept that this was really happening. But they probably did a little better job at it than we did. But in any event, coronaviruses are not uncommon. They're a common cause of upper respiratory infections. We've had 3 deadly coronaviruses since 2002. We had SARS. We had the Middle Eastern Respiratory Syndrome, or MERS, back in 2012 or 2014? And now we have COVID-19. These are all coronaviruses. They're a little different than the upper respiratory ones because they hit the lower respiratory tree in the lungs. And that makes them deadlier. They also lead to something called adult respiratory distress syndrome, ARDS. I don't know. What are your thoughts on some of this?
I don't even know where. I know where she's going with it, and she's wrong. And I don't know how to stop her from going there. Even in the way she's saying it in here, she's saying that, this wasn't created in a lab, but it was created in a lab. She's really trying to have it both ways. I'm not sure what she's trying to say there. But SARS, MERS, all of these things, they're outliers. There's 19,000 coronaviruses. We have 3 that have been especially fatal. There's just nothing to do with what she's saying.
What is the purpose of saying it then? What is she trying to prove? Is she trying to say that this is a biological attack from China? Is she trying to say that this is something the Illuminati's doing to kill off old people and reduce medical costs? I mean, what's her point?
You think they would have made something that was a bit more silent and killed more suddenly then?
Yeah, and left the worker bees healthy and intact.
And then, of course, she's sitting there saying it could be lab created. There's already been people go through it, and there's not a known CRISPR package that has been found in its genome. Its genome's already been mapped.
Yeah,
we know basically everything there is to know about this thing. We know basically where it came from. We know the mutations it has. We know that it's that the proteins that allow it to enter human cells on its surface are not a perfect fit. Now, why on earth would you release something that's not a perfect fit when you could make it a perfect fit to enter the cell?
It would be far more effective, wouldn't it?
Yeah. It seems like it would be more of an accident for it to not be a perfect fit versus intentional for it to work perfectly.
Well, if you weaponize something, you want to make it efficient. And you also want to make it very short-lived so that, it doesn't interfere with your plans for the aftermath. You want to get rid of everything have it have a very high penetration rate. Now, COVID-19, for example, is, you're looking at a mortality rate of around 4 or 5%, and that's going down. That was equivalent to the Spanish flu, but society continued. We got through the Spanish flu. We're going to get through this. Hopefully, we're not going to lose as much of our population as we did with the Spanish flu. But we're going to have deaths from this. This is not the Black Plague. The other thing, too, is the contagion rate on it. That's the other thing that you would want in a weaponized virus. You would want it to have a very high, what they call R0. Now, R0 is roughly an idea. If I'm sick, how many people am I going to infect? Now, if I have the flu, I may infect one other person. If I have COVID, I could infect 2 or 3 other people. If I have measles, I could infect 20. And that's one of the ways that you look and see how quickly viral illnesses and pandemics spread. I don't know. Any thoughts on that?
I mean, I was reading an article the other day. The largest super spreader that we found so far infected 11 people.
In COVID?
Yeah, with COVID. And that's not an enormous amount.
No, it's not. It's well below the measles level. And we take measles seriously.
Well, we have to take measles seriously. The injury rate is 2 to 4 per 1,000 get encephalitis.
Yeah. I've heard it as low as 1 per 1,000. And, the incident rate of complications of any kind from the MMR vaccination is on the order of 1 in a million. So it's a basic risk to benefit ratio here. Let's go ahead and continue.
Somebody didn't go to a market, get a bat. The virus didn't jump directly to humans. That's not how it works. That's accelerated viral evolution. If it was a natural occurrence, it would take it up to 800 years to occur. This occurred from SARS-1 within a decade. That's not natural.
Bryan, is there anything at all that you can think of that would lead her to say it takes 800 years for this to happen? I mean, anything?
If you were to say that it was a direct relation from SARS-1 to this one, that was the virus that it mutated from to get here, you could almost say that. Someone's actually gone through the data on that. The problem is that this is a mutation of an already known coronavirus that is not exactly SARS-1. And the estimated time it would have taken to get from that would have been 20 to 80 years, and we've known about that virus for about 40. So I don't know why she thinks that it had to come from SARS-1, but she's dead wrong.
Did I mention that she was fired from her research position?
Yep. Oh, do you actually know there's even more to that story? She left. She left her place at the National Cancer Institute, and couldn't find. As it went to a startup in California, it folded immediately. And then for the next 5 years, she was actually a bartender. Nobody would pick her up.
Interesting.
That's a star researcher for you.
It's an interesting article right here in Ars Technica. Fired scientists back to peddling anti-vax COVID-19 conspiracy theories. I'm going to go ahead and put a link to this in the description of this video because this is actually very interesting. I think it gives a lot of insight. Back as the patron saint of science denial. That's what they refer to her as. This is a fascinating, and make sure you hit some of these links as well, because this is just a fascinating article that they wrote. So in any event, let's go ahead and get back to this.
And do you have any ideas of where this occurred?
Oh, yeah. I'm sure it occurred between the North Carolina laboratories, Fort Detrick, U.S. Army Research Institute of Infectious Disease, and the Wuhan laboratory.
$3.7 million flowed from the National Institutes of Health here in the U.S. to the Wuhan lab in China, the same lab where many people have said that this coronavirus infection first originated. We also now know that NIAID, the department associated with the National Institutes of Health, of which Dr. Anthony Fauci is in control, had already been conducting experiments with the Wuhan lab in the past in regard to coronavirus. If Dr. Anthony Fauci cannot be honest with the public about his connection to this lab, then Fauci has to go.
In 1999, I was working in Fort Detrick in USAMRIID there, and my job was to teach Ebola how to infect human cells without killing them.
So now we have a couple of more things to unpack. First, why is the United States giving money to a virus lab in China? Where do influenza viruses generally come from? Where are they first identified, Brian?
They're typically identified in the Near East.
Correct. And an institute such as the Wuhan Virology Institute would be doing a lot of that work on behalf of the CDC and on behalf of the United States, right?
Yeah, because we want to get ahead of the situation. We want to be able to have a working flu vaccine for what we think is coming.
Right. Now, would we send our own team there, or would we use the existing lab facilities that are there, that are experts in doing the same research just as we are?
Why would we relocate people to a place where they're foreigners in a culture that they don't necessarily understand or want to be a part of? Use the existing structure.
And that's a pretty reliable way of doing it, isn't it?
Very much so.
All right. So I don't really have any issue at all with sending some money to the Wuhan Virology Institute, especially $3.5 million. Is that going to fund a chemical weapons program for the Chinese People's Army?
I probably wouldn't even fund a dinner party for the Communist Party.
I don't think it would either. So we're not talking about a huge amount of money here. Second of all, now she was doing research on AIDS in 1999, right? And now she's teaching Ebola how to infect people without killing them in 1999. She had a busy year, didn't she?
Well, not to mention, she's also time traveling again, because I believe she actually goes on immediately after this to say that Ebola was incapable of infecting human cells until she taught it to. But Ebola has been infecting and killing people since at least 1976.
Possibly even before that.
Yeah. The first outbreak we've noticed was Democratic Republic of Congo, 77, 76?
Somewhere in there, yeah.
And it was isolated shortly thereafter. We know exactly when it came up. If she's going to rewrite history like that, she better have a damn good reason to think that.
Well, I just think it's very interesting how pivotal she's been in all of virology since 1999. Worked for a couple of years as an actual researcher, PhD level researcher, and then ended up as a bartender. I think that's kind of an interesting life story.
Ebola couldn't infect human cells until we took it in the laboratories and taught him.
It's hard to ignore the death tolls. People have been dying. They are dying from this in quite alarming numbers. How do you reconcile that?
It's pretty easy when you see, for me, when you see what the government has done, and that is that they took, quoting Dr. Birx,
we've taken
a very
liberal approach to mortality.
If my husband were to die, who has COPD, his lungs have fibrosis, his lungs would look exactly like somebody with COVID-19, theoretically, but he has no evidence of infection. So if you're not testing and you don't have evidence of infection, and if you walked in there today, they'd call it COVID-19. And we hear this from the doctors and nurses who are upset.
I've seen so many doctors online that have made their own webcam videos, just perplexed by the protocol that the CDC had given them.
Well, last Friday, I received a 7-page document that sort of told me that if I had an 86-year-old patient that had pneumonia but was never tested for COVID-19, but sometime after she came down with pneumonia, we learned that she had been exposed to her son, who had no symptoms, but later on was identified with COVID-19, that it would be appropriate to diagnose on the death certificate COVID-19.
Part of our job, Brian, is that we fill out death certificates. I've filled out thousands of them. I'm sure you've filled out quite a few of them as well.
More than I care to think about.
Well, Death is as natural part of life as birth is. That's the way I look at it. And everybody that's born is eventually going to die. But in any event, it comes to people like you and I to try and figure out initially what they died from.
Mm-hmm.
Now, if I have AIDS and I die of AIDS, what do you put on my death certificate?
Well, you didn't necessarily die of AIDS. What is it? What did you have?
Pneumocystis carinii pneumonia.
Oh, that's it. I would have had you down for. I would have had you down for a pneumonia from a non-typical bacteria.
Mm-hmm.
Resulted from AIDS.
Correct. So there are two things that go on a death certificate. One is what killed you immediately. And everybody dies of cardiogenic shock. Their heart stops. Okay? That's not what we're looking for. We're looking at the imminent cause of somebody's heart stopping. All right? Could be a bullet wound could be a stroke, could be a heart attack, could be a ventricular rupture, could be cancer, right? Mm-hmm. Now, that's the primary cause of death. Now, there is another section on the death certificate that says contributing causes to death. So, if I die of an infection, my cause of death is sepsis, for example. Let's just say that my cause of death is sepsis. Now, if I'm a diabetic, have high blood pressure, and heart disease, do those go anywhere on the death certificate, even though not any one of those things directly caused my death? Were they contributing?
Absolutely.
Okay. In other words, had I not been a diabetic, I may have been able to fight off the infection. So even though the infection killed me, the diabetes prevented me from fighting it off and was a contributory factor. COVID can be a direct cause of death, can it not, from respiratory failure and pneumonia?
Absolutely.
All right. Can it be a contributory cause of death if I'm critically ill with pneumonia and I have a heart attack and the heart attack's what kills me? Do you put COVID down?
Absolutely.
Okay. So perhaps that clears up some things for the audience. This is something that a lot of people don't seem to understand. And there's something else that we're going to talk about here in a minute, and that's DRGs. But let's go ahead and let this finish for a little bit, and then we're going to get to the DRG section, and then you and I can chat about that for a moment.
When I'm writing up my death report, I'm being pressured to add COVID. Why is that? Why are we being pressured to add COVID to maybe increase the numbers and make it look a little bit worse than it is? I think so.
Why would they want to skew the number of deaths due to COVID-19?
Well, fear is a great way to control people. And sometimes people's ability to think for themselves is paralyzed if they're frightened enough. And that's not where I want people to be. I want people to say, we're going to get through this. I'm going to use my head. I'm going to go to different sources. I'm going to listen to different sources. And I'm going to think for myself, because that's what America's about.
If someone dies with COVID-19, we are counting that as a COVID-19 death.
You don't die with an infection. You die from an infection.
Bryan, does that make a damn bit of sense to you? You don't die with an infection, you die from an infection?
If somebody has a heart attack, at the same time they're fighting Vibrio vulnificus on their leg, they have a traumatic infection that is affecting the status of their blood. It is affecting the ability. It is affecting circulation. It could be putting extra strain on the heart.
And the heart fails.
Factor.
But the infection's not the direct cause of death. The heart attack is.
Doesn't matter.
The infection is a contributing cause of death, but you didn't die directly from the infection. And that seems to be what she's trying to say. You don't die with an infection, you die from an infection. It's just not true.
I forget that everyone suddenly is devoid of all infections when they die.
That'd be a hell of a great, would that mean strychnine would be a very good antibiotic because it would cure their infection immediately as soon as they quit breathing?
Yeah. Oh, is there something? Oh man, that would be amazing. It's like, well, this person has an obvious infection. It would be a good time to get them something that would otherwise cause them to to get torsades because
Yeah.
they're already on an antiarrhythmic that gives them long QT.
Yeah. Okay. Yeah. That would just be absolutely great. Oh, you have pneumonia? Here, chew on this cyanide capsule. All right.
They'll solve everything else.
That'll fix it right then and there. All right. Now, the other thing is hospitals are paid based on something called diagnostically related groups. You're familiar with that, of course, aren't you?
Yes, and I'm terrible at it.
Well, here's the deal. Let me give you a little hint on how to get a little better for it. Now, what hospitals do is, in the old days, they would just bill for whatever they did and the government would pay the bill. Well, so when Medicare and Medicaid are paying the bills, they can tell the hospitals what they're going to charge because they handle a huge percentage of the payments for healthcare. So they will tell the hospitals what they're entitled to get for a particular thing. So instead of billing for everything, they're going to say, well, the average person with community-acquired pneumonia requires 3 days of hospitalization. We're going to pay you for the usual treatment for 3 days worth of hospitalization. Mm-hmm. And what happens then is if you have to stay in the hospital for 5 days, you only get paid for 3 of them. But if you get them better and then discharge them after 2 days and treat them as an outpatient, you get that extra day's worth of payments. You see how that works? So the key to it is get them out of the hospital as quickly as possible and at no time have them in the hospital unless it's absolutely essential beyond the normal hospitalization time. The second thing is if you have a community-acquired pneumonia, there's a certain amount of money that they pay you for that. If you have a community-acquired pneumonia and you have a complication that requires you to be put on a ventilator or in the ICU, obviously that DRG goes up because now you have an extra thing that needed to be done. There's been a complication and you can pile something else on it. So if you treat somebody if I treat somebody in my office, they may come in because they need a wound sutured up. Okay, that's one thing. But they're a standard patient of mine. I'm treating them for diabetes and high blood pressure. And while I'm stitching up their wound, I review their labs. I review their blood pressure. I review their blood glucose readings. I counsel them on diet. So when I write up the bill at the end of that, and I have diagnosis number 1, laceration to forearm. Treatment is 5 sutures. Number 2, review and address diabetes. Number 3 is review and address hypertension. I get paid more for that visit than I do for simply suturing that wound. So that's why if you have COVID, even if that's not what kills you, it's to your benefit to record it as one of the treatment or one of the diagnoses that you're treating. You see how that works?
Oh, absolutely.
I thought I lost you there I almost had a heart attack there for a second.
Sorry about that.
I thought maybe the whole stream was down and I just carried on for 5 minutes again on mute or something.
Oh, no, Bob, you're all good. Don't worry. We won't take your heart attack and write it down as COVID.
Well, that's okay. But if I do have COVID and the heart attack, you better put both on my certificate.
You got it.
All right. Epidemiology. It's important for epidemiology. There's a lot of benefits to making sure that you do a complete diagnostic list for every hospitalization. And that's what the guidance from the CDC was. Mm-hmm. So in any event, you got anything else to add there, Select?
Oh, no, nothing much to it other than, I don't know, other than this 13 grand and the 39 grand that they refer to often. Yeah. That doesn't even get close to covering it. And if you know this as well as anybody else, them saying they're going to pay that is 8 months of repeatedly filing paperwork and arguing with them for them to agree to pay 80% of their agreed upon $13,000, which didn't cover.
They still owe me for trim and toenails in 2003. I'm serious. But in any event, why is there a difference between COVID and COVID requiring ventilator treatment? Because ventilators are more expensive. It's a complication. It's a higher level of care, so it gets paid more. Now, it doesn't matter if it's COVID or a standard pneumonia or a broken leg. you're still going to get a certain amount of money for a diagnosis. And $13,000 is not an unreasonable amount.
No.
Either's $39,000 for that matter.
That they are being incentivized to list patients that are sick or have died with COVID-19.
Yeah, $13,000 for Medicare, if you call it COVID-19.
Right now, Medicare has determined that if you have a COVID-19 admission to the hospital, you'll get paid $13,000. If that COVID-19 patient goes on a ventilator, you get $39,000, 3 times as much.
And you've killed them with the ventilator because you gave them the wrong treatment.
All the things that just don't make sense, the patients I'm seeing in front of me, the lungs I'm trying to improve, have led me to believe that we are operating under a medical paradigm that is untrue. And I fear that this misguided treatment will lead to a tremendous amount of harm to a great number of people in a very short time.
My next question is about Italy. I want to know why Italy was hit so hard.
Oh boy, oh boy, oh boy.
Now, before we move on to Italy, Bryan, when you're dealing with a brand new disease process that has some features of familiar diseases, we talked about this earlier, is it uncommon to have different opinions on the proper approach to this disease when it first comes out before we have a lot of data?
Well, of course. It looks like something else. It looks like it could be a couple of things. We have a couple of modalities to treat each of those things. There's going to be a split opinion on how to deal with it. But what is she saying? The ventilator is a treatment. The ventilator is literally a last-ditch effort to get oxygen into these people's blood to prevent ischemia and acidosis.
Yeah.
It's not a treatment. It's literally the last thing we want to do.
It's life
we
support.
want them to be on a BiPAP. We want them to be on high-flow oxygen. Anything to keep their O2 sats up.
Now, we can put people on a vent just willy-nilly. There's no complication to that, right?
Oh, I mean, besides the fact that you have to put them under essentially a respiratory arrest and make it run off the machine only, because breathing around it is kind of a big deal. A lot of them are going to require a layer of sedation that is just absolutely beyond what people want. And there's a chance that once you go on vent, you may never get to come back off of it. The last thing we want to do is just throw someone willy-nilly on a vent.
Yep. And for example, can you be on a vent forever? No. You can't be on an endotube forever. You can be on a vent, I guess, for an extended period of time. But, the issue that you run into is if you have to be on a ventilator for more than about 2 weeks, you need to be trached. You can't, the short term is the tube in the mouth. Then they cut a hole in your neck. Now, the other thing that you run into with ventilators is that you are bypassing all of the protections that we have from the crap that's in the air that we breathe in, the cilia in our nose, our mucosal membranes, the things that block dirt, viruses, bacteria. Is it at all uncommon for people to get infections when they're on ventilators?
We do our best to make sure that never happens because they are devastating when they happen.
Yeah, people die from them. That's why, there's good sterile technique used. Things are cleaned regularly. Prophylactic antibiotics are sometimes used. That's ugly stuff. So it's not something that we just do because, it's Tuesday. Let's tube Mrs. Jones. Come on. And when you have somebody that is going into respiratory failure, the treatment is ventilator. Now, there are different approaches to ventilating people to avoid what we call barotrauma, the pressures that we're using. Yep. And maybe that's what this gentleman's talking about. Maybe he's talking about the lead up to having to put them on a ventilator where we're using BiPAP or CPAP in positive pressure ventilation. But the idea that we're killing people by intubating them, if we didn't intubate them, they would be dying anyhow. I mean, that's why we intubate people, is because they're dying and they can't breathe. Is there any other reason to intubate somebody long term? I don't mean temporarily, but long term.
Nothing's coming to mind all of a sudden. I mean, pretty much you ventilate somebody if they have paralysis of their diaphragm long term otherwise.
Well, thank you for tuning in to part 3 of my discussion with Dr. Bryan Peck on the controversial video Plandemic. And in this episode, we allowed them to present their evidence that coronavirus was created in one of a very select number of labs, and we looked at the evidence that they presented for that. And in our fourth and final episode, we're going to talk about the controversies surrounding the treatment of coronavirus patients and how medicine in general approaches a new disease. So in the meantime, take a moment and hit a like and subscribe to my new channel, Common Sense Science. You can also head over to Bob the Science Guy and have a look and see what we've got going over there. I think you'll enjoy both. So signing out from Northern Michigan, this is Bob the Science Guy. Thank you very much for stopping by, and we'll see you again soon.